Hello everybody, this is Dr. Podel again. So this is the second part of ABG and acid-base disorder. Let's dive into it. So let's start with the disclaimer. This lecture is intended solely for the education purpose. This is meant for fourth year medical student to elucidate the concept of ABG analysis and acid-base disorder. This should not be used as a direct source for decision making, which should always be done under the guidance of an attending physician. The learning objective for this lecture include assessing the type of respiratory failure, understand their clinical implications. Then we will be talking about both respiratory and metabolic acidosis and alkalosis. We're going to apply them in clinical settings. Then we'll be discussing about different causes of hypoxemia. We'll also take an opportunity to discuss about indication of oxygen therapy. Then we'll learn about AA gradient, and we'll learn how to apply AA gradient in diagnosis of hypoxemia. Like we discussed in part 1, ABG interpretation starts with identification of primary process, whether it's a respiratory or metabolic. So let's assume normal PCO2 is 40 and bicarbonate is 24 and normal pH is 7.40. If your patient has acidemia and the carbon dioxide is more than 40, so most likely that acid is coming from carbon dioxide. So that means the primary process is respiratory. If your patient has acidemia and carbon dioxide is less than 40, so it's not coming from carbon dioxide, it has to come from metabolic source. So that's why the primary process is going to be metabolic. On the other hand, if your patient has alkalemia and then carbon dioxide is more than 40, so that alkalemia, the alkali is not coming from carbon dioxide. It has to come from metabolic side. So similarly, if patient has alkalemia and the carbon dioxide is less than 40, most likely primary process is respiratory. So that's how you start interpretation of ABG with identification of primary process. Always check for the degree of compensation. Primary process, remember, they only partially compensate. They cannot completely compensate. Compensation cannot do total correction except in the case of chronic respiratory alkalosis. That's the only primary disorder where compensation can result in normal pH. Remember, you cannot overcompensate. So talking about compensation and the time frame, the respiratory compensation is immediate. On the other hand, renal or metabolic compensation takes some time because it includes involvement of the kidneys, and the kidney has to excrete or hold bicarbonate, and that process is going to take almost 6 to 12 hours, and it requires almost 24 to 48 hours to reach that steady state. So metabolic alkalosis is compensated with hypoventilation, but you cannot really hyperventilate when your PCO2 goes around 55 to 60. Then metabolic acidosis is compensated with hyperventilation, but it's not possible beyond PCO2 of 12 to 14. So primary respiratory process, either acidosis or alkalosis, compensation done by kidney by readjusting bicarbonate absorption, reabsorption in proximal tubules. So let's talk about compensation. So this slide is very, very important. I have put all the formulas that you need to know about compensation. Let's just start with the metabolic acidosis. We're going to do some practice in part 3. So let's just start with the metabolic acidosis. So in metabolic acidosis, obviously there is more acid and bicarbonate is going to be low. So you want to calculate expected PCO2, PaCO2. So which is done by Winter's formula, 1.5 times bicarbonate, which is carbon dioxide number, then plus 8 plus minus 2. So that's how you calculate, and we'll do some example in this part 3. In metabolic alkalosis, so this is the formula, change in PCO2 is equal to zero point 0.7 into change in bicarbonate. So let's say somebody has a bicarbonate is 34, let's say. What is normal bicarbonate? Is 24. So how much up? So up by 10. So change in PCO2 is equal to 0.7 into that 10. So 0.7 times 10 is equal to 7. So we can expect up to rise of 7 in PCO2 with that change of 10 in bicarbonate. So if you have more than 7, a greater rise in PCO2, it tells you about hypoventilation and primary superimposed respiratory acidosis. On the other hand, smaller rise tells you about primary respiratory alkalosis. So that's how you calculate. So remember, PCO2 should never rise above 55 to 60. It's not possible. Then let's talk a little bit about respiratory acidosis, and we're going to apply all this principle in the third part. So in acute, if the pH decreases by 0.008 for every 1 millimeter of mercury drop in PCO2 above 40. So example, if somebody has a PCO2 of 50, so how much more? 10 more. So 10 more, pH decreases by 0.008 times 10, which is 0.08. So that means with that PCO2 of 50 is supposed to bring that pH down to 7.32, because remember 7.40 is a normal pH, and then you expect 0.08 down. So 7.32 pH is explained by that CO2 of 50 millimeter of mercury. And thing will be different in chronic, because kidney already starts taking care of bicarbonate, so there will be conservation of bicarbonate. So for that region, pH decreases by just 0.003 for every 1 millimeter of mercury rise of PCO2 above 40. So similar formula for respiratory alkalosis too. So, so I also put the formula for respiratory acidosis and respiratory alkalosis. So remember, you fall more than you rise. So that's how I remember this formula. So respiratory acidosis is caused by type 2 respiratory failure. So talking about respiratory failure, type 1 is hypoxemic, means they have low oxygen. What is low oxygen? Any number less than 55 in blood gas is hypoxemia. So then type 2 is not only hypoxic, they also have a hypercapnia. They have more carbon dioxide. So remember, carbon dioxide is more permeable than oxygen. So if somebody is retaining carbon dioxide, the trouble is not in the respiratory membrane. The trouble is higher up in the ventilatory tract, starting from the cortex, going down through the nerves up to diaphragm. So that's where the trouble is. So hypercapnia occurs because of the trouble higher up. On the other hand, hypoxemia occurs because of trouble in the respiratory membrane, either in the alveolar side or in the respiratory membrane or in the vascular side of the respiratory membrane. So since it takes some time to fix those, so alveolar side example is pneumonia, respiratory membrane could be interstitial lung disease or congestive heart failure, or could be on the vascular side, which is pulmonary embolism. So you need to fix those primary pathology to treat type 1 respiratory failure. On the other hand, type 2 respiratory failure, it happens when somebody is not awake enough. They are not maintaining their airway, and as soon as you put them on ventilator, their type 2 respiratory failure is fixed right away. So it's very easy to correct type 2 respiratory failure. On the other hand, type 1 respiratory failure, you need to treat the cause. Then type 3 is perioperative. It is a subset of type 1 failure. Type 4 you see with any kind of shock. So talking about type 1 respiratory failure, it is also the indication for oxygen. So like we talked about, when you are doing pulse ox, any number less than 88, that corresponds with, when you do ABG, that corresponds with number of 55 or less. If somebody has a oxygen number in ABG less than 55, or they have what you call pulse ox less than 88, that is called type 1 respiratory failure. That is hypoxemia. So that is the definition. So they qualify for oxygen. Some people, they are chronically hypoxic. What happens with the chronic hypoxemia? What happens in the pulmonary circulation? In the systemic circulation, hypoxemia causes vasodilatation. On the other hand, in pulmonary circulation, hypoxemia causes vasoconstriction, results in pulmonary hypertension. So chronically hypoxic people, they tend to have a pulmonary hypertension. And pulmonary hypertension causes pressure on the right side, and they ultimately they undergo failure of the right side, which is called cor pulmonale. And people with the cor pulmonale, over the time, they tend to develop swelling, pedal swelling. If we have a chronic hypoxemia to bone marrow, what is going to happen? So there will be more erythropoietin secretion and results in polycythemia, hematocrit more than 55 or 56 or more. So those are the three P's: pedal edema, pulmonary hypertension, and polycythemia, which are the features of chronic hypoxemia. If you have a feature of chronic hypoxemia, that magic number with the pulse ox is no longer 88. It goes a little bit higher, that is 90, and that 90 of pulse ox corresponds with 60 of ABG, oxygen, PaO2 of 60. Sometimes people are fine during rest, but they tend to desaturate during exercise. So in those people, you have to document that they desaturate below those reference number we just talked about. Sleep is a little bit different. That desaturation that we just talked about needs to be sustained. It has to be sustained for at least 5 minutes. Clinical case. So 72-year-old male with a 50-pack year history of smoking, quit 10 years back, FEV1 25%, very severe obstruction, grade 4. Patient gets shortness of breath with limited level walking, has less than 1 acute exacerbation per year, has a gold B, that's grade 4, no cardiac disease. Upon discharge, his medical team obtains oximetry at rest, which was 92%, and they make him walk around, and with ambulation, SpO2 went down to 82, both on room air. Once he was put on 3-liter oxygen per minute, his oxygen saturation came up to 95% with ambulation. How would you manage this patient? Discharge on oxygen, no oxygen, discharge on oxygen during exertion only, with exertion and sleep, or 24/7? And the correct answer is discharge and no supplemental oxygen. So let's talk about oxygen supplementation and COPD. So the trial, not MRC trial, was done in 1970s and it was published in Annals in 1980. It included 203 COPD patients with severe resting hypoxemia, and they were studied on plus minus oxygen. So the criteria was the criteria we just talked about: saturation less than 88, equal to 88 or less than 88 at rest, or somebody with a right-sided heart failure or polycythemia less than 90. So that was the criteria, and what they found, really interesting finding: long-term oxygen therapy decreases mortality and improved quality of life. So if you look closely, somebody who used this oxygen more than 19 hours, that means continuous oxygen 24/7, those are the people who got maximal benefit compared to just nocturnal oxygen therapy. And if you look at the time frame, they didn't get benefit in the earlier phase. The benefit actually started appearing around that 15-month time frame. So you need to use that oxygen for long term before you start getting benefit out of it. So which is very, very important to understand when you are giving oxygen to your patient. They need to use it most of the time during the day, at least 19 hours. And then the benefit starts appearing after 15 months or so. And the reason for difference between these two groups, why people getting 24/7 or more than 19 hours in a day, they got more benefit, it was not clear. So what about oxygen supplementation before 2016? So the indication of oxygen was saturation less than or equal to 88, or saturation less than or equal to 90 with right-sided heart failure or polycythemia. And then supplemental oxygen is of no benefit when you have saturation 88 to 90, and then hypoxemia with exertion only when your saturation is less than 88. And then many oxygen prescription in the United States is for this indication, and oxygen cost is almost $2 billion per year. And we don't know what to do for those people with exertional shortness of breath responding to oxygen but with a normal SaO2, especially during pulmonary rehab. That's when they decided to do this study called LOTT, which was published in NEJM. So in this LOT study published in NEJM 2016, they included more than 3 times patient than the original study, 738 COPD patient. So they included saturation 89 to 93 at rest, and then 80 to 90 with exertion after 6-minute walk test. So 43% of the patient made that desaturation with exertion criteria. And remember, 30% had saturation less than 86. Then they titrated oxygen to keep that saturation more than 90, 24/7 with resting hypoxemia. And then for exertional hypoxemia, they also titrated oxygen to keep saturation more than 90. And they look at outcomes. Primary was death or first hospitalization for any cause. The secondary outcome was quality of life, shortness of breath, 6-minute walk distance, and depression. The finding of LOT study was very, very interesting. There was no benefit to supplemental oxygen when resting saturation is more than 88. or when saturation with exercise was more than 80, as you can see here. So current evidence supports oxygen therapy if your saturation at rest is less than 88, or if your saturation is less than 90 or equal to 90, if you have right sided heart failure or polycythemia with hematocrit more than 55. Current evidence does not support oxygen therapy when you have exertional hypoxemia of medium level up to saturation of 80. Area of uncertain for oxygen therapy include what to do if you have exertional hypoxemia less than 80. We don't know. We need to do further study. We also don't know exertional shortness of breath responding to oxygen but with an acceptable saturation more than 80. So we don't know what to do. So this is the scope for the future study. So let's discuss about respiratory chain. It starts with central nervous system, peripheral nerve, and respiratory muscles. Anything wrong with all these three structures results in type 2 respiratory failure. Type 2 respiratory failure means increase in carbon dioxide. Remember, carbon dioxide is more soluble than oxygen, so anything wrong with respiratory membrane is going to make that oxygen low. If the carbon dioxide is high, the defect is not in the respiratory membrane. The defect is higher up and it happens to be central nervous system, peripheral nerve, or respiratory muscles. Then airways and lung are the next structure in the respiratory chain. Anything wrong with these two results in type 1 respiratory failure. And last but not the least, cardiovascular system and hemoglobin. Any disorder of these two systems results in type 4 respiratory failure. I would like to recall the fact that phrenic nerve is supplied by C3 to 5. So if somebody has a spinal cord trauma and the level affected is above that level, they tend to get phrenic nerve paralysis. So what does that mean? These people are ventilator dependent at that point because that phrenic nerve is no longer functioning anymore. So let's talk about 5 causes of hypoxemia. Starting with the VQ mismatch, intracardiac shunt, hypoventilation, high altitude, and diffusion limitation. So if you look at 1 and 5, those are similar conditions. So in both conditions, 1 and 5, what they do, there is something wrong either on the alveolar side or in the respiratory membrane or in the vascular side. So classical example, PE, COPD, ARDS, or interstitial lung disease. So that is one group. Then the shunt is the second group. And if we look at the third and fourth, those are the condition where AA gradient is normal. It's not raised, which actually differentiates from other 3 causes. So 5 causes of hypoxemia, there are only 2 conditions in which AA gradient is normal. Either you're in the Mount Everest, that is high altitude, or you have taken something that makes you feel like you're in Mount Everest, something like, sedative like benzodiazepine. So those are the 2 conditions where AA gradient is normal. Then another thing that I'd like to point out, in all causes of hypoxemia, if you give supplemental oxygen, if you increase FiO2, that results in resolution of hypoxemia, but not in case of shunt. So only shunt does not respond to increase in FiO2. So these are the features that helps you to differentiate different causes of hypoxemia. So let's calculate A gradient. So this is the formula for A gradient. So start with big A. So big A, as you can see, the first part of the formula, which is constant, which is 150. As you can see here, 0.21 times 713, so that constant is 150. If somebody is on a supplemental oxygen, you need to change this number. So let's say somebody is on 5 liter, FiO2 is going to be 40%, that is going to be 0.40, and you calculate this number. So in our case, it's going to be 150. Then the second number you need is PaCO2, which is carbon dioxide number from ABG. Let's see our ABG. In our ABG, the carbon dioxide number is 65 divided by 0.8. 65 divided by 0.8 is going to be 81.25. So 81.25 is PaCO2 divided by 0.8. So total big A PaO2 is going to be 150 minus 81.25, which is 68. So how much is the AA gradient now? So AA gradient is going to be 68 minus small a. Small a comes from ABG, which is oxygen number of ABG, which is 55 here. So 68 minus 55 is going to be 13. What is the normal age appropriate AA gradient, which is divided by 4 plus 4. So in our case, a patient is 48-year-old, so 12 plus 4 is going to be 16 is the AA gradient, and in our patient has AA gradient of 30. So this is how you calculate AA gradient. All right, let's talk a little bit about respiratory alkalosis. So hyperventilation reduces arterial PCO2 and consequently increases the arterial pH. The most common causes of respiratory alkalosis are early shock. When somebody has a shock, they actually breathe faster because they have a metabolic acidosis because of the lactic acid, and they are trying to clear that by breathing faster. In fact, this is the earliest acid-base disorder of hypovolemic shock. Some people with CNS lesion, either from infection or from CVA, they tend to breathe fast. Some people, they have a psychiatric condition. Some people, they have hepatic insufficiency, anxiety, hyperventilation, we already talked about psych, and then lung disease can result in respiratory alkalosis. And remember, aspirin is a classic agent that gives you mild metabolic acidosis. Remember, mild metabolic acidosis with significant respiratory alkalosis when they have taken in moderate doses. If they have taken in high doses, it can actually cause respiratory depression. And remember, bicarbonate never falls below 12 in response to respiratory alkalosis. It's not possible. So compensation for respiratory alkalosis is by metabolic acidosis, right? So how do you compensate? How much change in bicarbonate you expect? You multiply that PCO2 number by 0.2 if it is acute, and then 0.5 for the chronic. So that's how you calculate the compensation. So let's talk about metabolic acidosis. A very important slide. Please spend some time to go over this slide. So starting with a normal anion gap metabolic acidosis, classic mnemonics is hard ups, hyperelimination, acetazolamide, RTA, diarrhea, ureteral diversion, pancreatic fistula, sniffing toluene or blue sniffing. So out of that, RTA and diarrhea, those are the two most common cause of normal anion gap metabolic acidosis. Talking about high anion gap metabolic acidosis, classic mnemonics is Goldmark, published in Lancet. So glycols Oxprolin, it's a metabolite of chronic Tylenol uses. So classic nursing home patient whose Tylenol level is negative, but they still can get something called pyroglutamic acid, which can result in formation of oxprolin, results in anionic gap acidosis. Then lactic acidosis, either both L-lactate and D-lactate. D-lactate, classic of short bowel syndrome, lab assessed, is usually L-lactate, and we have to ask a lab to measure D-lactate if you are interested to measure if you have a high clinical suspicion. So metformin can cause lactic acidosis, especially in those people with a creatinine clearance less than 30. Reverse transcriptase inhibitor, propylene glycol can cause, thiamine deficiency can cause. Methanol, aspirin, and renal failure are the cause of high anion gap metabolic acidosis. Remember, renal failure does not contribute much to anion gap acidosis. Classic rule of thumb is divide your creatinine number by 2. That's the maximum anion gap acidosis that renal function can contribute. So somebody with, let's say, 10, maximum anion gap is around 5, that can be contributed by renal failure. So what does that mean? In any patient with renal failure, just don't attribute renal failure as a cause of high anion gap acidosis. You need to look for other causes. Then last but not the least is ketoacidosis. DKA, alcoholic or starvation ketosis, can cause formation of ketosis and can result in high anion gap metabolic acidosis. So urine anion gap is very important to measure if you have a question about whether it's a diarrhea versus renal tubular acidosis contributing. So the way to interpret it, that formula is, so the way you calculate is urine sodium, you add that with urine potassium, and then you subtract chloride from that number. So if the number is negative, mnemonics is negative, so if it is coming from the gut, that number is going to be negative. And if that number is more than 0, that is not coming from gut, it's coming from kidney, because kidney is not making ammonium. So that's the way to interpret it, urine anion gap. All right, so this table is really important table. It helps you to answer many questions in the exam. So as you can see here, whenever you have very high, very high anion gap, you need to be thinking about alcohols like methanol, ethylene or propylene glycol, and sometimes you can also get with ketoacidosis and lactic acidosis. On the other hand, isopropyl alcohol and ethanol and acetone, these conditions, they won't result in anion gap. In these three conditions, anion gap is normal. That kind of helps you to distinguish between different kind of alcohol. So whenever somebody has very high anion gap, you're supposed to calculate osmolar gap, and then osmolar gap, if it is more than 10 to 15, you think about alcohol. What alcohol you are talking about? You're talking about methanol, ethylene glycol, or propylene glycol. Methanol you get with windshield fluid, or you see with some kind of poisoning that people get when they are drinking alcohol. You might have heard about poisoning with alcohol, so this is because of methanol. And then ethylene glycol is antifreeze. So antifreeze, typically these people, they present with flank pain because of the calcium stone, and very high anion gap and osmolar gap. So, and then salicylate, on the other hand, causes mild anion gap acidosis. It also causes respiratory alkalosis. So um, that's all about this anion. So let's talk about metabolic alkalosis, which is primary elevation of plasma bicarbonate with a subsequent increase in pH. Um, so cause could be due to loss of acid or addition of alkali, which is called generation, or it could be from regeneration where there is enhanced renal reabsorption of bicarbonate. So what happens with the vomiting? You lose hydrogen, you lose chloride, you lose the water. So it results in alkalosis, hypochloremic metabolic alkalosis. If you vomit too much, what happens? There will be decreased kidney perfusion. When kidney gets less perfusion, then renin-angiotensin system comes into play and secretes aldosterone. Aldosterone, what it does? It causes distal tubular loss of hydrogen ion and potassium. So, in chloride depleted patient, in the proximal convoluted tubule, so rather than chloride, it is the bicarbonate that gets absorbed. So that's what happens in the proximal tubule. On the other hand, in the distal convoluted tubule, your patient is going to lose more hydrogen ion and potassium. So you started alkalosis from mouth by vomiting. Now your kidneys are going to maintain that alkalosis by proximal tubular absorption of bicarbonate in absence of chloride, and then also distal tubular loss of hydrogen ion and potassium due to effect of aldosterone. So that's what happens in the kidney. So that's why, to mitigate that loss from kidneys, you are supposed to expand the vascular volume by isotonic fluid. And typically you would like to give 0.9 normal saline, which has chloride, more chloride. So that more chloride actually helps, interferes with absorption of bicarbonate in proximal convoluted tubule, and that expands and also inhibits that aldosterone, and you are not going to lose any more hydrogen ion in distal convoluted tubule. So that's why you are supposed to expand volume with isotonic normal saline with potassium chloride as indicated. So let's talk about metabolic alkalosis types. So saline responsive is typically they have very low urinary chloride, less than 10. And a classical cause of this is vomiting, or somebody with a nasogastric suctioning, or somebody who is a diuretic, and sometimes post-hypercapnia state too. So remember, in the hypercapnia, what happens? For every rise of 10 PCO2, bicarbonate will rise by 1 in acute, 3 in chronic. So let's say somebody has PCO2 of 50, that means went up by 10. So their bicarbonate is supposed to go up by 1 or 3. So if it is acute, it goes by 3. If it is chronic, it goes up by 1. So let's talk about saline unresponsive or saline resistant. So these are the people with the edematous state, and these people typically have a higher urine chloride, more than 10. And the classic cause are mineralocorticoid excess, either with a primary hyperaldosteronism or secondary to what you call intravascular volume depletion in CHF or cirrhosis, or ACTS excess or licorice. And other cause of saline resistant are refeeding alkalosis or excessive alkali administration, or even severe hypokalemia can cause saline resistant metabolic alkalosis. So let's talk about other anion gap calculation, starting with the stool. So 290, which is a plasma osmolarity, then you subtract 2 times sodium and it's still potassium. So if the number is less than 50, it's secretory, there is not much difference from the plasma. If the number is more than 75, it's osmotic. Osmotic tends to get better with the fasting, and usually the volume is less than 1 liter. On the other hand, secretory tends to be high volume, and it persists to the fasting. So that's a classical clue that helps in the diagnosis of diarrhea. And inflammatory, on the other hand, they have blood and WBC in this stool. Let's talk about urine anion gap. The formula is urine sodium, you add urine potassium, and then you subtract urine chloride. So the number of sodium, potassium, and ammonium should equal to chloride, because those three make positive compartment while chloride makes the negative compartment. So electrically it has to be 0. So since we don't include ammonium, so if you calculate that gap is due to ammonia, which is not measured. So anion gap of urine less than 0, that means kidney is good enough to make ammonium. Negative. On the other hand, positive anion gap means kidney is not making ammonium. So significant amount of that positive charge compartment would be occupied by sodium and potassium, and that results in positive anion gap. So the way I remember is negative. So if it is coming from the gut, that anion gap is going to be less than 0. Negative. So it's coming from the gut. If it is coming from the gut, that means kidney is good enough to make ammonium. So what are the kidney causes? Different RTA, type 1, type 2, and type 4. RTA, they can cause non-anion gap metabolic acidosis. Remember, two most common cause of non-anion gap acidosis is diarrhea and renal tubular acidosis, and the way you differentiate between those two is calculating urine anion gap. If urine anion gap is less than 0, negative, means it is coming from the gut, means diarrhea. They are losing bicarbonate from the GI tract. So that's all for this second part of acid base. Our third part is going to be on practical approach to acid base. Thanks for watching. If you have any further question, feel free to reach out to me at my email as paudel@mcw.edu. Thanks again.